everybody. Welcome to the Vital Stuff podcast. I'm your host, Dr. Gail Lebovic, and today I'm really excited to share this episode of Vital Stuff with you. Today, we're talking to Dr. Stephen Kurtzman. He's a board-certified radiation oncologist who's been helping men fight the battle of prostate cancer since 1996. He's currently director of Prostate Brachytherapy and president of Western Radiation Oncology Society. He's treated thousands of men using cutting-edge techniques that we call real-time intraoperative prostate brachytherapy. You're going to learn all about it, that and more. Steve is not just a top-tier doctor, he's world-renowned. He's a teacher. He's trained many physicians across the country and around the world. His work has been widely published in numerous peer-reviewed journals, and he's really helping us advance the field of prostate care. As you'll learn, Steve's a super nice guy. He is someone who cares deeply about his patients and getting the best outcomes. I hope you're going to enjoy this episode as much as I do. It is really a must listen. So join me as we welcome Dr. Stephen Kurtzman.
Hey, Steve. Great to see you. Thanks so much for joining us today. How you doing?
I'm doing great, and I am just thrilled to be here. I was so excited when you gave me this invitation. Thank you so much.
Oh, no, thank you. I know how busy you are and how amazing you are, so I really, really appreciate it. It's an honor to have you here.
Thank you.
I'm really interested about our topic today, which obviously is about the prostate gland. I don't think the prostate gland gets enough respect. I don't know about you, but I just don't. It's an amazing organ, and so I'm super excited.
Great.
I kind of want to break it down today. And I realized, even though we've done a lot of work together, in the breast field, and I learned a tremendous amount from you, I don't know kind of your story about how you became so involved and so interested and so innovative in the field of prostate health,
Sure.
Really, I would say men's health. So I'd love to hear a little bit about your story just as
Sure.
we get started here.
Yeah, it's funny. Over the last even couple of decades, I do nothing but prostate brachytherapy, and I never had that as a plan. It really just developed organically. So it really started back in 1999. I had moved to California and joined a practice in San Mateo, California in 1998. This is a period where prostate brachytherapy, permanent seed implants, was skyrocketing. And the folks I was with said, hey, can you start a prostate brachytherapy program? And I lied through my teeth and said, sure, I got that. I can do this. But fortunately, there was a company called Bard Urologic that actually had a program that they would come in and start a turnkey operation, including bringing in physicians to teach people like me, or urologists teaching the OR staff. They brought in all the equipment that we needed. And it was great because from day one, you were assured that you were going to be doing good quality implants because you had a proctor standing over your shoulder. Mm-hmm. So I started doing the procedure. I realized very quickly that I liked it. And again, things were expanding so quickly back then that the folks from Bard came to me within, a few months and said, hey, you're actually pretty good at this. Why don't you come join us and fly around the country teaching it? And I accepted that, and I started going around the country teaching. And I would always learn, what I loved about that experience, I would always learn something from the people that I was teaching that I would incorporate into my own procedure. So it was actually very valuable for a young brachytherapist to actually see what other people were doing, even though I was there to teach them. I always felt like I learned more from teaching than they learned from me. The real thing that changed, where I realized I can bring my program anywhere, and we have programs all over the country at this point, was that I was introduced to a group of urologists in a town called Los Gatos, which is maybe 35, 40 miles away from San Mateo. And they had a group that was doing lithotripsy together. And we plugged in the brachytherapy program, and that was really a wild success. And that's what made me realize I can bring this program anywhere. And over the next several years, that's exactly what I started doing. I would actually identify groups of urologists, either with their own surgery centers or hospitals or we're sort of independent, agnostic to what facility we were doing at, that would like to do brachytherapy. Now, the reason this was and continues to be really easy for me to start programs is there is no radiation oncologist that there are no radiation oncologists that do this procedure, and it's a real shame. They're very intimidated by this. Radiation oncologists in general aren't really looking to get into scrubs and go to the operating room. They're much more comfortable, in a radiation department, contouring things on a computer, handing it off to a physicist. They're generally not procedure oriented. And why I say that's unfortunate, because demonstrably the brachytherapy is clearly the treatment for prostate cancer with the highest cure rates and the lowest complication rates. So it's dramatically underutilized. Remember, I said that things were really skyrocketing back in the late 90s, early 2000s. And that was true. And that was a double-edged sword, because, quite frankly, there were a lot of people getting dragged into brachytherapy that really didn't want to do it, and they just weren't doing a good job. So there were urologists out there who had a bad taste in their mouth. The other two things that really sunk brachytherapy was the advent of IMRT, intensity modulated radiation therapy, which indeed was a significant improvement over the existing techniques for doing external radiation. So it definitely was a better treatment for patients. And it was incredibly well reimbursed, which actually backfired on radiation oncology world, because urologists started building their own centers. And then they started shifting away even from prostatectomies and brachytherapy, because the financial rewards for owning a linear accelerator were tremendous. The other thing that came on board around the same time was the Da Vinci robot, the robotic prostatectomy. And that was sort of a renaissance for urologists wanting to get back into the field of prostatectomy. So those two things happening simultaneously really kind of sunk the progress that brachytherapy was making. I just never stopped. So I'm one of the guys that I just never stopped doing it over all these years. And instead of fading away, my practice has just tremendously grown over all these years. And I'm proud of this. We're probably going to do close to 2,000 cases in 2026 at this point.
Whoa.
Yeah.
Oh my God, that's amazing. That's unbelievable.
Yeah. And that's my story.
That's an amazing story. And we're going to unpack different parts of that, because I know you threw a lot of terminology out there that we're going to dive into,
Sure.
like brachytherapy, IMRT, all of those things I want to talk about, because I think that would be very valuable,
of course,
for a lot of people who are going to listen to what you have to say today. So we'll come back to all of that, but it's a fabulous story. In a lot of ways, I feel like we're very similar. I had that same experience in breast cancer surgery, right? You see a white space and you kind of wonder, well, why the hell aren't we doing it this way? It's less surgery, which, I mean, I'm a surgeon, so I like to do surgery, but it's less damaging or deforming to the patient, less complications, quicker recovery, everything to make people's lives better when they're going through a real shitstorm.
Right.
So I love your story, and I'm so proud of all the stuff that you've done. I think you deserve lots of kudos, and I know a lot of your patients are grateful. I know a lot of them, actually.
Thank you for saying that. Very nice of you. Thank you.
So again, appreciate your time today, because I know seeing 2,000 patients in a year is not easy.
I have 6 cases over in Walnut Creek this afternoon, so we have plenty of time.
Whoa, 6 cases! That's incredible.
Yeah, we'll do as many as 15 cases in a day. They're very efficient, very quick.
That's great for you and for the patients. Another theme that came up in your little introduction, which has been one of the things that's really disappointing to me in my career in medicine, is you mentioned that radiation therapists, which you are one, and we're going to talk about that whole, field. You mentioned that brachytherapy, what's better for the patient, didn't take off because it wasn't necessarily financially as good for the radiation therapy. That is so disappointing to me. And we see the same in breast cancer surgery. We see it all the time.
Right.
And that has been overall my biggest disappointment in medicine, to learn that medicine is actually a business.
Right.
So, and it comes up a lot actually with the people that we speak to. So it's kind of a sad situation, but thank goodness there are people like you and like me who really do the best we can for patients.
That's
And
right.
we're all about that.
That's right.
So
I mean,
let's
in
talk.
addition to that, though, just it's not
Sure.
it's not strictly that. The maybe even more is the lack of expertise that radiation oncologists have at this. So I don't want to say that it's strictly a financial motivation, but there clearly is a conflict when it comes to you get paid a lot more to do IMRT than brachytherapy, but also there's just not many people that know how to do it or want to do it.
Well, I think that brings up the issue of postgraduate training, right? Everybody goes through the system, they go to medical school, they do a residency, and then they go out into the big world to practice, right? When you're doing brachytherapy or when you're doing innovative approaches to clinical medicine, that takes training. I don't care if it's injecting Botox. You have to go out there and you have to learn. And that's another piece that I think is critically important in life is continual learning.
Right. And I always say you have to go outside your comfort zone, right?
Absolutely.
My first brachytherapy case, I was laying in bed at night the night before, nervous as could be. My first case took 3 hours, right?
Yeah.
And you have to persist. You have to be willing to be uncomfortable and to learn.
Yeah. We talk a lot about conquering fear. Like
Right.
for me, the most recent thing is my team telling me I had to be on social media. I had to do a podcast. I have to do all these things, which I really didn't want to do. I had no social media. I had nothing. But in life, if you're going to continue moving forward, the biggest thing you can do is conquer your fears.
That's absolutely right.
So I know I'm very familiar with that feeling, as I know everybody is.
Right.
You know, otherwise you get paralyzed
Correct.
and stagnant.
Right.
And grow old, which we can't allow.
Nope.
So let's talk about the prostate gland because it's kind of hidden from sight, right? It's a mysterious part of our body. It's essential to life and I would say procreation.
Correct.
So it's a very important organ. Can you just, in a nutshell, I gave you a tip there. In a nutshell, tell us about the prostate gland that you're so familiar with.
So the prostate is the structure. It sits right in the middle of the pelvis. It sits just below the bladder, and in fact, the urethra, the tube that essentially runs from the bladder through the penis to urinate, runs right through the middle of the prostate. Okay, and in fact, this is why men, as they get older, tend to have a lot more urinary difficulties because the prostate tends to grow. It's called benign prostatic hypertrophy, which is a fancy way of saying.
Why does that happen?
Probably just the influence of years of testosterone. Testosterone will, essentially feed, if you will, a prostate, and it just gets bigger. This is why older guys, I tell people this all the time. When I'm at a sports event, like in a stadium, and I'm in the men's room, I look for the teenager to get behind at the urinal because I know he's only going to be there for a few minutes. I never get behind a guy with gray hair because they take forever.
No, I love that. That's a great takeaway pearl, right? Never get behind a man with gray hair at a urinal.
In the men's room. Yeah, takes forever.
Hilarious.
But anyway, really what the only thing it does for all the trouble it causes, both benign and with regard to prostate cancer, all it does is it makes the fluid that liquefies semen. That's pretty much it. That's all it does.
Okay, so it makes the fluid like we have blood plasma, right? It makes the fluid that carries the sperm.
That's correct. That's right. That's really all it does.
It's a very important job.
Yep.
Now, how about some tips about keeping your prostate healthy and maybe preventing these issues as men get older? Or are we going to call it menopause?
No,
menopause?
No. In fact, it's kind of almost the opposite. Again, it's because of testosterone, really, the presence of testosterone, that it keeps growing. And there's really, there's some people that say you should be eating like cooked tomato products that have lycopene. There's saw palmetto. Unfortunately, none of these things have strong clinical data, showing a true benefit, like in a randomized trial or something like that. So unfortunately, I don't think there's a lot that you can do to prevent BPH. But luckily, there's a lot of treatments for BPH, including medications like something called Flomax. The other name is tamsulosin. There's multiple procedures where if things get bad enough, they can go in and essentially core out the prostate in several different ways. There's a whole bunch of different procedures. So for benign situations, there's a lot of things that can be done to fix those urinary difficulties.
Oh, that's good. So
Yeah.
you mentioned BPH. I just want to clarify that's benign prostatic
That's
hypertrophy.
not cancer. That's just a big prostate that's grown over time. So it's funny, we call a normal sized prostate, we kind of refer to a normal sized prostate as what a 20-year-old would have. You know, guys in their 60s, 70s, nobody has a quote normal sized prostate, right? They you know, occasionally you'll see somebody, but it's almost a misnomer because prostates do tend to grow over time.
So here again, size does matter.
Size matters. It's a big deal.
We can have a lot of fun in your end of the business. So in terms of size, it's roughly about the size of.
So again, in the 20-year-old, it's generally say it's about the size of sort of a large walnut, right? But you know, and in numbers wise, we measure in you know, cubic centimeters or volume. So 25 cc gland is what we call normal. But I mean, most guys in their 60s, 70s, they're probably in the 40s or 50s. I mean, I've seen prostates 200 cc's. They can get really, really big over time.
Mega prostate.
Yeah.
Now, what about selenium? I've heard selenium is supposed to be good. You know, Brazil nuts have a lot of selenium.
Again,
There's
sort of anecdotal evidence that these things all help.
Urban myths.
I wouldn't call them myths. I mean, I never presume to say, oh, that's crazy, that doesn't work. What I'm saying is we don't have the type of compelling evidence that we doctors tend to like to see to declare, okay, this is a helpful thing, right?
Anything
that doesn't
else
mean it doesn't help. It just means that we don't have that kind of class 1 evidence for it.
Yeah,
right.
The traditional kind of scientific.
Yeah, I'm never dogmatic, and patients will ask me about that, and I'll always tell them, like, look, it's certainly not going to hurt you, and it may very well work. Right, so I never discourage it or poo-poo it, or you know, it might very well work. The question is, the issue is that we don't know that they work necessarily.
Got it. So anything else like flossing or brushing that you can do to keep your prostate?
No, not really.
Okay, all right. Well, there you have it from the expert.
I'm 63. I take Flomax.
You're 63. You don't look it.
No, thank you. But yeah,
but
I don't know.
Right.
I haven't measured my prostate, but it's definitely enlarged. And as I get older, my urinary problems continue to persist. It's super common.
Don't get behind the guy with gray hair.
Exactly. Don't get behind me at the Giant Stadium.
Living healthy. That's what we're all about.
Yep.
Diet, exercise, living healthy, work hard, keep you
That's right.
That keeps you young.
That's right.
Yeah. So you mentioned surgery for benign prostatic hypertrophy, BPH, and here again, I'm sure a lot of people are facing that. I've heard about some new technologies. Anything that piques your interest on that since you're 63 and maybe looking down the road at what you might do?
Yeah, you know, I'm not a urologist. I'm a radiation oncologist. I do nothing but prostate. So I don't necessarily know the nuances of that procedure since I don't do that procedure, but there's so many, ranging from the traditional sort of roto-rooter, where like it sounds, they're just kind of reaming out the central part of the prostate, opening it up. There's things like aqua ablation, where they're using high pressure water jets to remove tissue.
Yeah, I've heard about that.
There's something called green light laser to vaporize the tissue. There's these little type of plastic devices that they can insert within the prostate to sort of pull the prostate open centrally. That's not actually removing tissue. That's just pulling the central part of the prostate out towards the periphery to open things up. There's a steam procedure that you can use to kill some of the prostate tissue. So there's a lot of options. Again, I don't feel qualified to say like this would be the best in everyone's circumstance. You're better off talking to the urologist about, you know, what particular procedure, you know, they do, why they like it, your situation. The point though is there is a lot of procedures that can be done, and they're pretty well tolerated. and
Yeah.
don't have a lot of side effects. In fact, one of the things that I worry about when I do my seed implants, guys with significant urinary problems, the only side effect of my procedure is urinary difficulties for several weeks afterwards due to swelling and irritation. If a guy presents with significant urinary obstructive symptoms when I meet them, I will ask their urologist to do something to fix those problems. And the reason is they will sail through the procedure, their side effects will be minimal, and they'll be peeing like they're 16 again for the rest of their lives. So my experience is that guys who do these interventions are just really happy that they did.
Oh, that is a great little nugget too.
Yeah.
So in other words, before they have their prostate cancer treated with radiation, if they have trouble urinating, they go in, they get that fixed first,
First.
and then treat the
That's
prostate
right.
cancer.
Right.
Brilliant.
Yeah. It
Brilliant.
makes things a
That's
lot
great.
easier for everybody.
Nice little tip. And again, I'm sure every situation is different. As we know in medicine, there's no one way for each patient. So it is really important to check with obviously the urologist
Of
and
course.
the radiation oncologist doing the treatment.
Right.
Well, let's move on. If is there anything else, any other tips or
Nope.
anything we haven't?
I
Okay.
mean, BPH is not my wheelhouse. So I just know I take Tamsulosin and it helps.
Okay. Well, that's handy. Um, let's move on to the issue of prostate cancer because I don't know. Well, obviously, you're doing 2,000 cases this year. What I was going to say is, I don't know about you, but I am hearing more and more about prostate cancer. And is the incidence of prostate cancer actually increasing, or is that just our aging population? What's the scoop there?
It's always hard to tell because there is an aging population, and obviously prostate cancer um, is more common as we get older. It also has to do with screening. So, for instance, whatever it was 10, 12 years ago, they came out with a recommendation to stop routine screening. That was a disaster.
Yeah.
So
Yeah.
the quote incidence, if you looked at prostate cancer, was going down, but the problem was we were finding everybody after that few-year delay,
Later
so many guys were more high risk than they would have been otherwise, right? The whole point of screening is to find people, obviously you know this better than anybody, screening is to find people at an early stage when you have a viable intervention to make that better. And that's exactly what the PSA screening does. You find it at
Okay,
much
tell us
earlier
about
stages.
the recommendation for PSA screening because this is an issue that we have in breast cancer screening
Correct.
all
Same
the
thing.
time.
Very
Every 5
analogous.
years,
Yep.
they change the
Right.
rules.
Right.
So tell us the best recommendation that you do for yourself and your family for prostate cancer screening.
Probably start screening at age 50. If you have a family history of prostate cancer, probably start checking the PSA, even considering it at 40. And it's just an annual blood test. It couldn't be easier. It really couldn't.
Could not be easier.
Now, the reason, though, that it's controversial, it's not completely out of line that there's idea of this screening because, quite frankly, PSAs an elevated PSA does not mean you have prostate cancer. Obviously, there's false positives. There's guys with high PSAs walking around who don't have prostate cancer. There's guys with low PSAs that do have cancer. So it's not a perfect study. But an elevated PSA will then probably lead to an MRI, probably lead to a biopsy. You know, any medical procedure has some risk. Biopsies, infections, sepsis, bleeding. And very often we find prostate cancers that are essentially clinically insignificant, meaning low-risk prostate cancers, which don't necessarily need to be treated because they're just probably not destined to cause the patient a problem, or if it was going to cause a problem, it might be years down the line. So that's the problem with screening, is that we do find a lot of guys with low-risk prostate cancer that doesn't necessarily need to be treated, but now you know it's there. And now you've opened the can of worms of, do you pick a treatment? Are you going to watch it? And what does watching it mean? Watching it means serial MRI scans, serial biopsies. Again, you're submitting yourself to procedures with potential side effects, not the MRI, but of course the biopsies. So that's the reason why some people argue that maybe PSAs shouldn't be so routine. However, we tried that, and the number of high-risk patients we saw really just skyrocketed.
Wow, so many parallels to the breast cancer
Right.
world. I can't even tell you,
Yeah, it's the
screening
same. It's the same
mammography.
thing. Yeah,
It's exactly the same.
yeah,
And I'm a big fan of screening. I think early detection makes all the difference in the
correct.
type of treatment that we can have because we all know it's it's kind of a trajectory when we get these cancers.
Yeah,
Very few cancers are aggressive when they first start.
correct.
They start small, they're locally contained, they don't spread to other parts of the body. So if we can catch that cancer as it's just starting, and what I'm hearing from you, it's the same with prostate. Screening is critically important.
Right.
So now take me down the path. Somebody gets an elevated PSA, in some range. And then, as you mentioned, they're going to have a workup.
Correct.
And that may include imaging studies. Obviously, it's going to start with a physical examination.
Correct. Or it may not even, quite frankly. So an
Oh,
elevated PSA with or without a digital rectal exam is probably going to trigger everything. Okay. Now, a low PSA and an abnormal digital exam might trigger the same type of workup. But in the modern era, usually 90+% of the time, the patients will actually go for an MRI as the first step, what's called a multi-parametric MRI. And those MRIs are very good at showing suspicious lesions. And they're graded, the level of suspiciousness is graded from 1 to 5, 1 being nothing suspicious, 5 being the most suspicious. It's not diagnostic of prostate cancer, but it is an indication of the likelihood that if you go on to biopsy that there will be cancer. Okay. Now,
same as
yeah.
breast.
Now, the
Same.
next step, even very often, even if an MRI is normal and doesn't show any abnormalities, but there's an elevated PSA, really the next step is almost always biopsy. Okay. And really, that's what we depend on to get the most information, because the biopsy is going to show us not only if there is or isn't cancer, but the level of aggressiveness. Okay. And there's basically it's called the Gleason score. And the Gleason score is determined by a pathologist who looks at the tissue from the biopsy. And they see the cancer cells, and those cells have features that are predictive of how potentially aggressive the cancer is. It used to be that was also a scale of 1 to 5. Generally, people agree that 1 and 2 doesn't even count as cancer. So now
Mm.
the lowest grade, lowest grade prostate cancer would be 3, and then 4, and then 5. Now, very often we'll see a combination of 2 types. So if you saw more type 3, and you also saw some type 4, that's called a Gleason score 3 plus 4. The first number being the majority of the cells they saw. You could also have more 4 than 3. That would be a 4 plus 3, which is considered an unfavorable intermediate risk. And then 4 plus 4, anything 8 to 10 is considered high risk prostate cancer and more aggressive.
Got it. Really helpful, Steve. Thanks for that summary. So, okay, now you've got the situation where you're going to undergo a biopsy. And I think a lot of people get confused about the fact that you can get to the prostate through the rectum. And it goes back to your introduction, basically telling us that the prostate sits way down there in the pelvis and they're neighbors.
That's
I
right.
mean, really, the rectal wall is touching
That's right.
the prostate
The
gland.
prostate sits right in front of what we call the anterior rectal wall. That's why we do when we do a digital exam, it's a rectal exam, because we're not feeling the prostate directly, we're feeling it through the anterior rectal wall.
Yeah, through the tissue. And it's a great way actually to do a minimally invasive biopsy with a needle.
And in fact, there's
It,
even better techniques that I would predict in 5 years, everyone will be doing transperineal biopsies, not going through the rectum, but going
oh,
through the perineum, the area between the scrotum and the anus. That's a big advantage for 2 reasons. You can and this is how we do the sedum plan as well, transperineally. We'll get into that, but you can access all parts of the prostate, back, front, much easier than going through the rectum, through the posterior part of the
wow,
prostate. And the infection risk is next to nothing because you're not putting a needle through the
that's
rectum.
awesome. Yeah.
Not a lot of urologists in this country are doing that yet. They will be. They will be, because it's a superior way of doing biopsies.
That's fantastic. So another great opportunity for innovation.
Well, as a
right
matter of
there.
fact, I'm working on a device right now to facilitate urologists being able to do this because part of the problem is there's just the equipment that's available to do this is archaic and terrible.
Yeah, it
Yeah,
makes so much sense.
yeah,
Makes so much sense.
yeah,
That's
yeah.
awesome. White
It's
space.
exactly right.
Go for it. I love that. Yeah. So we get the biopsy, and then obviously, again, just like in breast cancer, you have to make the determination between surgery and what type of surgery to be done. Are there partial
No,
prostatectomies? Does
not with
that
a
ever happen where they
prostatectomy.
take out a
However,
part of the
we can
prostate?
talk about this
Okay.
later. Focal therapy, meaning just treating part of the prostate, has skyrocketed over the last 5, 6, 7 years. I have very mixed feelings about that. We'll talk about that, but uh, not surgical. No surgery. If you're going to do surgery on the prostate, you have to remove the prostate. But you can do something called HIFU, which is high intensity focused ultrasound that essentially cooks the tissue. You can do freezing procedures. I can do focal seed implants. And basically what you're doing there is
Right.
you're just treating the lesion that you've seen on MRI, on where the biopsy was, and if there's something called a PSMA PET scan, which is very specific to prostate cancer. In fact, those are the only guys that I'll do focal therapy on, is guys who have an MRI, a biopsy, and a PSMA scan that's all concordant. It shows disease only in that area and nowhere else. Even that's not a guarantee that there's not microscopic disease elsewhere. That's why I'm not hugely enthusiastic about focal therapy. We can talk about that a little bit more. But that is skyrocketing as an option
Yeah.
these days.
Yeah. It's kind of like lumpectomy as opposed to mastectomy, but not with surgery. Okay. So if we're going down the path of surgery, we have to take the whole prostate out, which, I have a really thorough understanding of anatomy. I've been down in the pelvis in trauma cases, and I'm a general surgeon, so I've been there. That is tiger country. Lots of blood vessels, highly vascular. You've got the bladder, you've got the rectum, you've got the urethra. There's a lot going on down there. And even to this day, it's a scary thought, a little bit scary for me as a surgeon. But the robot has done some incredible advances in this area. Any comments? I know you're a radiation therapist, but any comments about robotic surgery for prostate cancer?
Yeah, yeah. I think you'll get a kick out of this. I refer to the robotic prostatectomy as the solar powered tanning salon. And what I mean by that is, and the literature bears this out, it doesn't change anything. The problem with the prostatectomy, number one, is not how you cut it out; it's that you cut it out. That's where the problems with complications come in. The other thing is, people don't realize this: prostatectomies have the highest failure rate of all the treatments, and the reason is, you're a breast surgeon. You're going to understand this completely perfectly. There's no margin. They leave cancer behind all the time. So if you have what's called extracapsular extension, meaning they cut the prostate out, they look at it under the microscope, and they see that the cancer has penetrated the capsule of the prostate, or if you have what's called a positive margin, which you see in lumpectomies, not infrequently, but in lumpectomies, you can go back and resect again if you want to, right, to get a negative margin. You can't do that with prostate cancer. So if you have extracapsular extension or a positive margin, the implication is that you almost certainly left cancer behind, and now the recommendation is to do a full 8-week course of daily radiation after the prostatectomy. Now, the prostatectomy in and of itself already has the highest risk of both incontinence and impotence for all those reasons that you said. Vasculature, the neurovascular bundle, the nerves that are responsible for erections are obviously right there. So it already has the highest risk of complications. Now, on top of that, if you need to do a full definitive course of external radiation, those complications skyrocket. It makes no sense, quite frankly. To me, the prostatectomy is a fundamentally illogical oncologic procedure. Highest failure rates, lowest cure rates. It's not my opinion. That's the literature shows.
When you have surgery, do you always need to have radiation afterwards, or not always?
No. So again,
Okay.
if you do the prostatectomy, the cancer is contained within the prostate, hasn't penetrated the capsule, you get negative margins, and the PSA goes to 0, you don't need surgery. You're done. But you still pick the treatment that prospectively had a lower cure rate and clearly had the highest risk of complications. So the prostatectomy actually works best on low risk patients, right?
Mm-hmm.
Because they're less likely to have those adverse findings of extracapsular disease or a positive margin. However, it still has a somewhat lower complication rate. It's still far harder in the short term. It's still far worse in the long term with regard to continence and impotence compared to other options. So there's never a situation, people ask me this all the time, is there a situation where somebody should have a prostatectomy? The answer is essentially no. Maybe for guys who have like terrible ulcerative colitis or Crohn's disease, we know that radiation can be a real problem for those they tend to have a lot of complications otherwise. Maybe in that circumstance, although over the last few years I've even started doing those because there's ways now that we can actually inject spacing agents to push the prostate and the rectum away from each other, dramatically minimizing the radiation to the rectum. But in general, nobody benefits from a prostatectomy, in my opinion. Now,
Wow.
I love my urologic colleagues. I consider urologists, because they're all I work with. I don't work with other radiation. I just work with urologists. I love my urologic colleagues. And you might ask then, why is it that the prostatectomy is still so prevalent? And quite frankly, the simple answer is urologists are not oncologists. They're not trained as oncologists. Prostate cancer is generally this much of what they do, right? They're doing kidney stones and incontinence and impotence and whatnot. And they're just taught from day one of their residencies, oh yeah, prostate cancer, you do a prostatectomy, it's the best treatment. Nothing in the literature supports that, nothing.
Wow. That is really an interesting perspective. It's an interesting perspective because the more we talk, the more I realize how complex every case
Right.
is, and how individualized the care
That's right.
needs to be, for sure. I think the
Correct.
care needs
Right.
to be customized. And I actually have really have a lot of empathy. And now I'm feeling pretty, sad about all the men who are going through this who need a multidisciplinary team.
That's the key. That is the key, right? So what I'm most proud of in my career is the vast majority of the guys that I work with stop doing prostatectomies
Wow.
because our treatment is better for everyone, including the urologist. And the patients do great. The urologist participates in the procedure, and everybody wins with a strong brachytherapy program.
That's awesome. So there you have it. The multidisciplinary approach to medicine,
Right,
really, which is the way to go. The
right.
holistic approach for,
That's right.
a kind of a better way to understand that. So
Correct.
let's switch gears to your area of expertise, which is radiation therapy or radiation oncology. I never really liked the term radiation therapy. It makes me, it sounds like you're going to a spa, which you're
Right, right,
definitely
right. I
not.
agree. Yeah.
And radiation is a bit mysterious as well because, it's kind of one of those invisible things and it does its job.
And it has scary
It
connotations
has,
to most people.
yeah, it
That's
conjures
right.
up a lot
Right.
of fear from the old days.
Or just because radiation, we're
Uh,
taught as something to avoid,
yeah,
right? People think of nuclear weapons and
right.
accidents at 3 Mile Island. But the way I always explain it to patients is radiation is like any other tool. Used properly, it's therapeutic, right? And I always say, I could kill you a lot quicker with a scalpel than I could with
Well,
radiation.
that's true.
But a scalpel is used by someone who knows how to use it in a therapeutic way. Same thing with radiation.
Very true. And what I love about brachytherapy, which I don't know what that word really stands for.
So brachy is the Greek word for in proximity. So
Ah,
brachytherapy as an overall concept means bringing a radioactive source directly to the area that you're treating, as opposed to teletherapy, which is external radiation, which is high energy radiation beamed from the outside at a tumor.
that that's
That's
helpful.
the difference between brachytherapy and external
Yeah.
radiation.
And I think most people know it as the seeds, for prostate cancer, meaning that these are small little seeds about the size of a grain of rice that are kind of supercharged with radiation sources that can be
Correct.
controlled. They can be
That's right.
highly controlled. And there's
Right.
kind of a low dose way to do that over a longer period of time. And I know you're going to explain this a lot better than I am. I just want to give you where I'm coming from. Um, And then there is high dose where you can take a single seed and you can move it around
Correct.
to certain places and bam, deliver a bigger dose.
Actually, it's a little misleading. It's low dose rate and high dose rate. It's actually the rate that's important. You actually get a higher total dose of radiation by far with a low dose rate implant. Okay.
That's
But
interesting.
yeah, so the seed implant, and this is why. So let me start by saying that I think that both seed implant and high dose rate brachytherapy, otherwise known as HDR, I think they're both good treatments. And in fact, we do HDR brachytherapy in our practice. We just choose not to do it for prostate cancer because we think that the low dose rate is superior, and I'll tell you why. There's three things about the. Actually, let me back up. If you don't mind, okay, if I just describe the procedure, the seed implant.
Please do.
Yeah.
Please.
So the seed implant is actually shockingly easy. What we do is we go to the operating room. Patients put to sleep. We start out by placing an ultrasound probe into the rectum. That ultrasound is connected to my treatment planning computer, captures sequential images of the anatomy. I contour out the prostate, the urethra, and the rectum. The computer does a three-dimensional reconstruction of the actual anatomy, which I can overlay on the actual ultrasound imaging. And then I literally plan out exactly how I'm going to place the needles and distribute the seeds, watching the dose distribution of radiation to the prostate, the urethra, and the rectum. And the beauty of this procedure is I would literally have to try to screw it up because I'm watching the doses that I'm achieving, treating the prostate adequately, making sure we don't overdose either the urethra and the rectum. Okay. We do the plan, place the needles, drop the seeds. Believe it or not, with all this going on, typical case takes about 15 to 20 minutes. Patient wakes up. There's no pain because it's all just done with needles. There's no cutting. Patient spends maybe 45 minutes to an hour in the recovery room and goes home and starts their normal day. That's the beauty of this. No incisions, no downtime. They literally, I've had guys play golf the same day as the procedure. I don't necessarily recommend that, but I mean, it's a bunch of needle pokes with the patient asleep.
Can they be around other people?
The answer is yes. So the amount of radiation coming from the patients is trivial, quite frankly. However, we do tell people to take three precautions. One, we tell them don't have any children sit in your lap. They can be around kids. We just tell them don't have them sit in your lap for 4 weeks. Now, even if a kid sat in someone's lap, nothing would happen. The kid gets more radiation getting in a plane and flying from San Francisco to LA than they would sitting in someone's lap. But it's easy enough to do, right? No radiation is better than some. We tell people to maybe spend a little less time, maybe keep a couple feet away from any pregnant women during that 4-week period. And we would tell them to wear a condom if they want to have intercourse during that period, because at least in theory, it's possible that a seed could come out in the ejaculate. But again, the amount of radiation coming from a patient is nothing. So the day of the procedure, the patient comes in an hour before the procedure. You know what I tell them? It's almost identical to what they're going to experience if they have a colonoscopy. That's exactly the experience that they have. They go to the OR, they fall asleep, they wake up, they don't really know anything happened, and they go home an hour later. That kind of sums up, from the patient's perspective, what happens that day. Now, they can resume all their activities. The only side effect they get, short term, and by short term, I'm talking about 3 to 4 weeks, pretty much everybody gets some degree of urinary difficulties during that period because of swelling and irritation of the prostate. Basically, it's a plumbing problem. Prostate gets kind of big and swollen, just makes it more difficult to empty the bladder. That always goes away. That's what short-term side effect. 3 to 4 weeks is generally the worst of it. That's also why we like to have their problems fixed ahead of time if it's bad enough to minimize. Because the worst case scenario after an implant would be somebody gets to the point they can't pee and they'd have to have a catheter put in. And if we do our patient selection properly, that's less than 1 to 2% of our patients end up with a catheter.
So you don't leave a catheter
We
in.
put in a catheter after the patient's asleep so we can visualize it during the procedure, take it out before they wake up.
Wow.
They go home without a catheter.
It's just incredible how things have advanced so far.
Yeah.
And I bet it's got to be really hard for you when you see a patient who actually needs surgery, and isn't a good candidate for brachytherapy, because again, it's going to depend on each individual case.
I just saw a guy, and this is another circumstance. I just saw a guy last week or the week before. He has Lynch syndrome, something called Lynch syndrome. And Lynch syndrome patients are highly susceptible, as you probably know, to secondary malignancies. I told him, I said, I'm going to go wash my mouth out with soap after saying this to you, but I think you probably need a prostatectomy.
Yeah.
And I felt, and the guy was heartbroken. He did not want a prostatectomy. And I felt terrible telling him that. But he'd already had colon cancer. I
Oh,
think it's not an absolute contraindication, but he was younger. I think he was at high risk for having problems with
yeah,
secondary
that's got to be
malignancies after any type
so
of
hard.
radiation.
It's got to be so hard when
It
you
was
have
awful.
something
Yeah,
that's so advanced you can
right.
offer patients.
Yeah. And luckily, that almost never happens.
Wow. Well, this has been
Let me get back. So you brought about HDR,
no
so I
problem.
lose track of it. So comparing HDR, and again, HDR is a good treatment, but the three things that I don't like about it is this: the procedure itself is 3 to 4 hour procedures. So they go to
Whoa.
the OR. First part's very similar. You place the needles, but instead of dropping the seeds, waking up the patient and saying, "Okay, go have breakfast," we leave these catheters coming out of the perineum, take them out of the OR, do a treatment plan with ultrasound or CT scan. Someone does a treatment plan, usually takes a few hours, bring them up, hook them up to the machine that runs this highly radioactive source directly into those catheters one at a time. That probably takes 45 minutes. During this, the patient's under spinal anesthesia the whole time. After that treatment's delivered, pull everything out, and you repeat it about a week later. Okay, so it's just a lot more cumbersome. But that's the least of it, because if it was better, right, you would do that, right? Because it's cumbersome, but it's not a huge deal. I think the other two things are more important, what I call the physics and the radiobiology. So for the physics, the energy of that radioactive source for high dose rate brachytherapy is literally 15 times higher than the seeds. It just penetrates a lot farther. So when you look at the dosimetry, the report that shows the exposure of radiation to the various tissues, the bladder, the rectum just gets a lot more radiation than it needs to. It's still better than external radiation, but compared to the seed implant, it's a lot more exposure to the bladder and the rectum with the radiation because of that high energy. And then the third thing is what I call the radiobiology, which is what has to do with the rate, I think is the most important. And the nice thing about the seed implant is that radiation is delivered over a period of essentially a couple months. The isotope we use is called palladium-103, and it has a half-life of 17 days, meaning after 17 days, half the radiation's been delivered. After 34 days, 75%. 51 days, 87.5%. So the easy way to remember it, 90% of the radiation is delivered in 2 months, pretty much entirely by 3 months. But the bulk of it's up front, okay? The beauty of that is that gradual deposition doesn't overwhelm normal tissue, where particularly the urethra. So the rate is important because the urethra is actually a relatively radio-resistant structure. So we never really see anything called urethral strictures or scarring of the urethra with the seed implant. With the high dose rate brachytherapy, you're literally getting the entire dose over those 2 very short periods. So you're getting a lower total dose, but the fact that you're getting it all at once over a matter of essentially minutes, that can be too much for some normal tissue to repair. And you will see things on occasion. Of course, not a lot, but on occasion, things like urethral stricturing. That's why we do HDR for other things, but not for prostate. We think the seed implant's a better
really
solution.
interesting. I've learned so much. It's incredible.
But again, I would never say I'm not. I think HDR is
Yeah.
a good treatment, and there are people out there that do it. And then again, you might ask them, well, okay, well then why, if what I'm saying is true, why do people do HDR? And I don't know if they'd put it this way, but HDR is a much more forgiving procedure for the doctor, not for the patient. But with HDR, you put the needles in, you put the catheters in, you hand it off to a physicist, and you do have the ability to move those sources to sort of either compensate for a bad needle placement or optimize what you already have. So it's less stress. When you do a seed implant, you get what you get, right? And I do tell people you're much better off getting high dose rate brachytherapy than getting a bad seed implant, okay? Because there's just not a lot of people out there doing seed implants or doing them well. But I would make the argument that the converse is also true. Nothing can approach the conformality and the radiobiologic advantages of a good seed implant, but you got to get a good seed implant. And that's why HDR is more popular, quite frankly. It's just easier for the doctors to do.
Yeah, that's so amazing, Steve. I mean, you have shared breadth of knowledge in such a short period of time. It's incredible. I bet you have patients coming from all over the place.
Yeah, we have patients. We have patients coming from all over the country, even all over the world. I had a guy come in from Japan last month that did this. Again, I don't look at that as a reflection of I'm so wonderful. I look at that as a sad thing that it's just not available to people.
Yeah.
And that's why we are literally starting programs all over the country. We're doing this now in Michigan, in Memphis, in Atlanta. We're starting a program in Cleveland, one in Nebraska. Just got off the phone with a group in Maryland, another in Arkansas. We're
brilliant.
I mean, again, it's a great opportunity for my practice, but I wish people had these as an option to begin with.
Yeah, it's great. Well, maybe we can work together on spreading not only the word, but the technology and some innovation.
Right.
And maybe we can, see how you could bring this technology to other physicians
Sure.
and more
Yeah,
people could benefit. Because after hearing this conversation, I would certainly recommend that in most cases, if it was applicable, if it was appropriate for patients, it seems like the way to go. Even though I'm a surgeon, I know we can be biased towards surgery, but when it comes to prostate cancer, I think people need to take a good look at all the options.
Well, and let me go off into two things here. So, and even within prostate cancer, it's not one option fits all. So, for instance, low risk and what we call favorable intermediate risk. 3+3 is low risk, 3+4 is favorable, low PSA. Those patients do great with a seed implant alone, just the seed implant. Cure rates less than 1% recurrence rates. I mean, they do great. For the patients with more aggressive disease, what we call unfavorable intermediate risk or high risk, Gleason 4+3 or higher, usually we'll do a combination of seed implant followed by a short course of external radiation because those are patients that generally are at risk for microscopic nodal involvement as well. Okay, the seed implant does a beautiful job. There is no better way, more elegant way to get the radiation to the prostate, but it doesn't treat the lymph nodes. So patients who are at risk for occult lymph node involvement will recommend combined brachytherapy and external radiation, sometimes with or without what we call androgen deprivation therapy, meaning giving them medications that temporarily knocks out their production of testosterone. Because testosterone, like I said, kind of feeds growing prostates for benign big prostates. It also has the same effect for prostate cancer. It tends to sustain cancer cells. So when you knock testosterone out of a patient, not only does it stop the growth, it actually starts to kill off much of the cancer. And in fact, if we do recommend hormone therapy, we want those patients on the hormones for about 2 to 3 months prior to the implant because it will shrink the gland, it will kill off much of the cancer, just minimizes how much radiation we need that there is to kill the cancer. Yes. So again, it's customized. Every patient is based on what we call the risk stratification group: low, favorable, intermediate, unfavorable, and high risk. And that's what we base our treatment recommendations on.
Well, that's what I love about the multidisciplinary approach, right? It's just essential. Well, I see we're up against our time limit here, but I'm sure I'd love to bring you back to talk about more things involved in men's health and the prostate gland in particular. So if you're up for it, I would love that. I want to thank you again on behalf of everyone who's going to hear this incredible episode. That all the information you've provided has been incredible. If you wouldn't mind sending over some materials, we'll link it to the podcast so that people can have more information and
absolutely
even a deeper
Actually, do you mind me giving a pitch to one website that does a great job?
Oh,
so
absolutely.
There's a website called prostatecancerfree.org. Okay. And in that website, and it's not by anybody who has an agenda. They're not selling a treatment. They're not pushing one treatment. There's a great section that you can compare any and all treatment options, the clinical data supporting them, breaks it into low, intermediate, and high risk. And it has a lot of difference. You can click on and off. So you could compare brachytherapy to external radiation to a prostatectomy. And when you look at that website across the risk stratification groups, it's really hard to argue that there's anything better than the LDR brachytherapy.
There you go.
People will tell me, you're a good salesman. I say, you know why I'm a good salesman? all I got to do is tell you the truth. And I
Yeah.
tell people, hold my feet to the fire. Look these things up.
Yes.
You'll see what I'm saying it's true. It's not that I have a car payment to make and I want you to pick my treatment, right? It really isn't. This treatment is just superior to most.
It's so important for people to do their own research. And I think,
Correct.
obviously, I mean, this just popped into my mind, but artificial intelligence obviously is going to come into helping people
Absolutely.
determine their treatment options, hopefully in a non-biased way.
Right. Exactly. That's right.
So again, Steve, thank you so much for your time. I really appreciate it. And can't say enough fabulous things about the work that you've done around the world, really, and taking this to the streets. So thank you.
That's
I
so
hope I
nice
get
of
to
you.
see
Thank you
you
for saying that.
sometime soon.
All right. It was wonderful. Thank you.
Thank you, Steve.
All right. Have a great day.
You too.